excellent friend, Bambi Francisco Reason, for this mental and behavioral health seminar. We will be your host. We have been your host since 2017, and we have been doing this for the last 5 years. And typically we hold these conferences and meetings, Invent Health meetings in person, either at UCSF or HP. But for the last 2.5 years, of course, as you know, we have been virtual. A lot in the world is starting to come back to normal as the pandemic is starting to wane. But we stay virtual, and there are some good things about it. We do know a few of our audience are joining from a global space, and we welcome them because us being virtual, this is possible. And so are some of our panelists who are joining across the country. So welcome to everyone to the Invent Health around mental and behavioral health. We wanted to address this topic. This has been somewhat of a well-received and asked for topic for several years now, but it is becoming more and more important in visibility. Things have somewhat deteriorated around COVID and in the mental and behavioral health space. Prior to COVID, this was a problem. 1 in 5 people did have mental health problems, but we did notice that in the recent studies that we are seeing 1 in 2 people having mental health problems, both mental health issues, mental illness, diagnosed or undiagnosed, including stress. This is way more than the physical health issues that we see. For example, hypertension being in 1 in 3, diabetes being in 1 in 10. So somebody 1 in 3 can be pre-diabetic, but mental health is 1 in 2, which is pretty high in incidence. It is way worse in our younger adults and children. What we see is in August 2020 and February 2021 data, that 74% of people 18 to 24 suffered from anxiety, depression, and stress. And that's a staggering number for our young adults. And then in the 5 to 11 year age group, we did see that even though COVID impacted only 1 kid out of 100,000, more ER visits were happening because of mental health issues. 1 in 100 kids went to the emergency room because of mental health issues. And that is really a big concern for all of us to focus on. Not only that there were mental health issues, but also the recent data, and you might have heard this in the NPR and other news that you are hearing, that even the education level has declined in kids. So both in math and reading, kids have declined in the last 1 year and almost gone behind by 1 year. We will talk about all of this. We have an impressive group of panelists who are experts in this space. And especially in the first panel, we will dig deeper into the impact of COVID on mental health, not for all ages, but also specifically focused on kids. We will also talk about the impact of social media, social isolation in kids, and the things that we did use during the COVID time to protect us from COVID, how that has impacted the mental health issues. Before we march on, as you probably notice, I'm opening today's discussion. I would like to pass it on to Bambi, but there are a few housekeeping things. We do have a Q&A session that we would keep taking live questions. Either people can speak up or type into the Q&A sessions. If you look at the bottom of your screen, you would be able to see a Q&A area. Please type away your questions. Across all of our panels, we will be able to take these questions live. So I would encourage that. And of course, tweet away. Some of our panelists are the ones that you probably would like to talk about on your tweet feed. So with that, I would also like to thank the sponsors. As you could see behind on our background screen, we are really thankful and grateful for having them sponsor our event, Invent Health, Mental Behavioral Health today. I would like to pass it on to Bambi who joins us today. Bambi.
Great. Thanks, Archana, and good morning, everyone. So I had a presentation to share, but I'm sorry, I'm not going to present it. In fact, I thought about moving this event too, but too much has gone into bringing everyone together, and this discussion is about mental health and how we treat it. We've gone through 2 years of grief in different ways, so I thought it would be relevant for me to share my story, where the grief runs very deep currently, but the joy and the gratitude far outweighs it. As the speakers know, I lost someone special a few days ago. He was my brother, and besides my husband, he was my best friend. He died in a tragic accident. He was killed by a drunk motorcycle driver while he was riding a scooter during sunset on the way to his beach house in the Philippines. For years, he had been planning this next chapter in his life, and he wrote a book, he built a platform, he gathered many to support his next venture. Then he sold and gave away all his belongings, his homes, furniture, he had a boat, assets, and along with his wife, they moved out to the Philippines to start a ministry. I mean, who does that? He finally made it to the island. It's hard to imagine being taken right when you reach the top of the mountain you've always wanted to climb, while being in love with his wife and his family and his purpose. Now I go back and forth between grief and gratitude. C.S. Lewis wrote, "In grief, nothing stays put." So the grief does hit me when I think of my loss. To be frank, when I pity myself because he's not here to make me feel better. My brother was very good at giving me wise counsel. He understood our human condition. He was typically the first person I called when I needed sage advice about relationships and conflict. But then I see my brother up in heaven with his small violin saying, "Seems like you're more sad for your loss than happy for me. If you can just see what I see, other people struggling, your pain is so small in comparison. I've spent enough time with you. I'm a part of you." So the more we impart the good qualities of the person we lost, the more we're growing back that part of us that was cut off. Then we have to exercise those qualities like a muscle, train ourselves. And then we end up honoring that person by showing a little bit of them through us. So I want to share what my brother taught me that kept me in the best mental state. Now, these are from a Christian perspective, but you can simply consider them helpful heuristics. So number one, practice forgiveness. My brother would say division is primarily due to unforgiveness. My brother was killed. I should have trouble with this. Some say, you should be angry. It's okay. Sit in that anger. Then depression is part of the grieving process. But I'm not angry. To apply this to what's happening in the world, I don't think we should teach our kids that all decisions made by our forefathers were to keep one race down and elevate another. Teaching kids bitterness creates division and instills anger in their hearts. My brother would say, "You are not worthy." Now, some of you might say, like, that sounds awful. How can I smile and think that way? Well, I'm not. In this world, we're constantly thinking of our self-worth. We are told to demand others to affirm us. That may give us temporal sense of self-worth, but we will fall back to earth and we will need to find worth again. For Christians, self-worth comes from God, and that never wavers. To apply this to what's happening in this world, there's far too much emphasis on teaching kids that kindness is affirming someone's identity. Kindness is keeping others safe in their fantasies to give them some false sense of dignity. If people keep looking to others for their dignity, they'll never be satisfied. We're even letting kids cut themselves up if that makes them feel better. How is that safe? Life isn't safe. And the sooner we know how to live through those dark moments, the faster we find our true identity. My brother also said, we don't deserve what we have. What does that mean? Well, I'm not worthy. I'm broken. and I will make mistakes, and I will sin against my brothers and sisters, friend and neighbor, sins big enough I shouldn't even have the wealth I have. Importantly, if you have what you don't even deserve, well, then everything is actually a gift. If more people understood that they were broken, we'd have less stigma about our mental health problems, and we'd have far more mentally healthy people. So conventional wisdom says, take your time and sit in your anger. Conventional wisdom says you are good, you are worthy, and you deserve the best, and you deserve safe spaces. Well, maybe conventional wisdom is wrong. The ways we treat the mentally ill are probably wrong. We're probably also asking the wrong questions. Certainly in mental health, some say we're only treating symptoms. This event will be very different from the others. It will not be a safe place. Our mental health is at stake. We will question conventional wisdom, from the way we diagnose mental health to the current top-down lockdowns and forced mandated healthcare protocols that keep people living in fear. We'll talk about what's behind the horrific statistics around mental health, and we'll talk about technological innovations that can really help, but ultimately it's not data and gizmos that get us to healthy mental states. It's forgiving one another and training ourselves to move from grief to gratitude. Thanks for letting me share that. Archana.
Thank you, Bambi. Thank you for setting the stage to really get closer to what we are all trying to solve for, is a healthy mental state for all of us. So thank you for sharing your personal journey through this. Thank you. With that, I would pick on the word conventional wisdom, and I would like to invite all of our first panelists, if you can unmute and come on the camera, I'll appreciate it. And from the conventional wisdom, I want to kind of zoom into the last 2.5 years, where we used what we had in our hands in the form of science and had one size fits all approach to lockdown, masking, isolating in the wake of COVID. And what we also witnessed is unintended consequences of approaching a pandemic in only one way. I wanted to understand and bring in all of our panelists, and we can start with I would urge if the panelists can introduce themselves as you are answering these questions in the beginning, and really ask the question around the big picture on the mental health. As we know, we just talked about the statistics, we talked about personal losses and griefs that people are dealing with. And the kids are getting impacted by not just mental health, but also decline in their knowledge and education. That these factors have fed into the deterioration of the mental health and continue to do so. To what extent did the lockdown and the mandates around COVID cause the mental health pandemic? We call it the silent pandemic of mental health. Which populations are getting hardest hit? And with that, I would like to introduce our panel, Dr. Ram Duriseti. He joins us from Stanford as a clinical associate professor. So Dr. Ram, if you don't mind introducing yourself and address this question of the COVID-related, approach that we have taken, how that has impacted in your practice, in your academic sense, and also the data, the mental health crises that we are witnessing right now.
Thank you. So my name is Ram Duriseti. I'm an emergency physician. My PhD background is in what they call engineering economic systems operations research, which is a very broad field, but it's primarily around modeling different systems, optimization, and in my case, computational decision modeling. First of all, Bambi, thank you for sharing that. It's incredible you're still here and you're talking to us right now. That's incredible loss. Thank you for sharing his message. I think the one thing that stood out most for me is his humility, and his grace. And that's something I've always looked at in my life. And, while this is not particularly quantitative or, domain specific, as is usually the place that I kind of operate, I think for me, I often reflect on the fact that, there's over 7 billion people in this world. I come from a country where there's, my parents came from, there was over 1.2 or 3 billion people. And I'm pretty sure there's someone who's digging ditches somewhere in central or northern India who is smarter than me. But what they're doing is digging ditches. I'm a beneficiary of my circumstances. I'm a beneficiary of the things that my parents have done and the opportunities I've been given, and simple luck. And I think it's really important for all of us to maintain that humility. So having said that, when we talk about sort of mental health in general, so just for background, when I'm at Stanford, I primarily work in the pediatric emergency department. I have exclusively done so, except for occasions where I've helped others with their shifts, since about 2006. In the community practice, I work in a facility that sees adults and children, and we're one of the 2 psychiatric receiving facilities for our county. We draw patients from San Francisco, from the airport, from south of us as well. So it's a pretty mixed pool with a pretty wide array of pathologies. And so, I've never been someone who has a strong grasp of the mental health care statistics in terms of actual numbers, but I've experienced it when I work all the time. And so if you were to ask me, what have I seen in terms of trends over the last 2 to 3 years? I've seen more substance abuse, but that was already on the rise. Whether it was an inflection point or not, I can't tell you. I've seen lots of patients who would go to facilities, and I don't want to name names because I can if I have to, but there are facilities near us, near my hospital, where I'd often refer patients for addiction care that were publicly funded, open to the individual, that have been closed, and they're still closed 2.5+ years later. And these people have now had this as a resource to go to, and yet it would be something that I would send them to on a regular basis. I don't know where to send them. For kids in particular, I think what I saw early on that's no longer occurring was that, I saw lots of kids coming to the emergency department for various reasons. But what happened early on in 2020 in particular, and maybe a little bit into 2021, were more serious cases. And by serious, I don't mean more profound depression, for example, or more profound suicidality. I'm talking about much more serious medical issues like ingestions. In other words, in the past, you might see someone they'll take 4 or 5 pills of something. There are very few things of which 4 or 5 pills are medically dangerous. That's not an absolute statement, but generally the case, depending on your body weight and what have you. But I was seeing very serious ingestions, more critical Tylenol ingestions, more critical Benadryl ingestions, more critical benzodiazepine ingestions if the person had access to them. So they were more serious acts of desperation that were more medically dangerous. That hasn't persisted, for what it's worth. But that was one trend. And then the substance abuse, as I said, and if you were to ask me the demographics that were most profoundly affected by all of the above, it was definitely teens and young adults. There's no doubt about that. And I'm happy to comment further as we go through our discussion.
Absolutely. And I would switch to Russ. Thank you so much, Ram. I would switch to Russ because the perspective of the clinician now comes to the perspective of the workplace. And Russ, you've been kind in the past to also support the first responders. In the last session, you actually shared that with us for the healthcare providers and nurses, but you have had in workplaces have offered your digital health solutions. What are you seeing in your space, and what are the policies and also the adoption in the workplace, how workplace is supporting individuals dealing with, first, the lockdown, second, coming back to work?
Well, yeah, thanks for having me, and my condolences as well, Bambi. I appreciate you sharing and sending thoughts. So I'm the CEO of Headspace Health, which we created from the merger between Ginger and Headspace. Ginger is an on-demand mental health system focused on supporting primarily employees of enterprises and members of health plans. And then Headspace is a mindfulness meditation app that really helps people think about their mental health earlier, really focused on prevention. How do we call it brush our brains, so that we are, taking care of ourselves prior to things getting more acute. So by bringing those two things together, we're really trying to cover the entire spectrum of mental health need, right? From prevention, keeping ourselves healthy, self-care, all the way through medication management, psychiatry, and behavioral health coaching therapy based on the level of need. And today we support about 4,000 enterprises, about 100 million covered lives, and millions of consumers that access our capabilities to support their mental health. And we've seen a few things. I mean, one is certainly the pandemic was a accelerant of mental health need, but I would say it's not accurate to say that it created the mental health pandemic. I mean, we were already seeing dramatically and scary increases in suicidality and anxiety, depression, well before the pandemic. The pandemic accelerated it. It was a little bit of a perfect storm of need, from isolation to, and loneliness, which we know is a big driver. I think for children in particular, were hit hard by the isolation. And, I have a pet thesis that masks, we know breathing is very important to mental health. And I think masks create sort of artificial breathing patterns that lead to some other downstream effects. And I think that what we see employers having done and the way they've reacted is to basically start to understand that mental health is not just something that you should support, but you need to support as a business continuity issue. When you've got 40% of your population that's presenting with, clinical levels of anxiety or depression, 33% of the workforce saying, I'm thinking about quitting my job because of mental health needs, because of burnout. You have to act on that. You have to respond to that. And so, the good news is, I think you're seeing understanding that investment is necessary. You're seeing that companies, even at the board levels, are recognizing this as something that they have to respond to in order to continue to be successful doing whatever they need to do as a business. And the investments that companies are making are meaningful. We'll see, we think this is countercyclical. We think that going into a harder economy over the next couple of years, which we're clearly going into, we'll see how that affects, where companies are going to place their bets. So far, the evidence suggests that mental health will be a spend increase area as companies realize that the ROI is highly positive. When you invest in mental health, you drive downstream healthcare costs broadly down. Cigna had a great study that showed that it's about $2,000 in the first year, so within first year, anybody who's getting any kind of outpatient mental health support will have a $2,000 savings downstream and $3,000 over 2 years in year two. So, I think that's starting to become more well-known, and as companies recognize the ROI, they'll continue to make investments here.
I would still want to address the conventional wisdom question off of all of our panelists, but I wanted to also bring in, thank you, Russ, elaborating that the trends in the workplace investment and into mental and behavioral well-being. Shifting a little bit towards Stephanie, because she's seeing kind of the similar landscape. What are you seeing, Stephanie? How are you seeing in the workplace, and then also how are you meeting the demands? Because it has exploded. I have noticed that because I've sat in that buying side of the table for a bit. So how are you meeting the demand, and how do you? The second part of the question is, how do you monitor and control the quality of the service as the demand explodes?
So similar to Russ, to what Russ is doing, we are 24/7 service, and we provide instant access to cognitive behavioral therapy programs and coaches and therapists, and we just introduced prescribing. So we do have a full spectrum of mental health care, and we saw tremendous growth during COVID, like 8x just in the mental health area alone. What I find fascinating about the dynamics is that, essentially COVID reminded us of a very simple truth, that we are all human and that humanity needs connection. And by being sequestered and isolated, it just exacerbated all of the sort of underlying stress, anxiety, and depression in our society. And then with the lack of access, so, essentially 25% of the people in the country that need mental health are getting access. And if you have an EAP, it takes like 20, 30 days to get an appointment. So it's really challenging. So I think employers are recognizing that to keep their employees engaged, connected, and productive during this remote hybrid workforce that we've now kind of emerged into from in this post-pandemic stage, and they really need a mental health service. And so that, I think employers, to Russ's point, are embracing mental health. It's a top demand. They're trying to do everything they can. I do think that the health insurance plans are a bit behind in getting to this mental health parity and recognizing the annual ROI and savings from mental health. That what's not as well understood in healthcare today is the connection between the mind and the body. We talk about it, and we do everything from diabetes to depression. So we do whole health, and our sweet spot is really serving individuals like who are living with co-occurring chronic conditions. So they have diabetes, depression, anxiety, hypertension, hyperlipidemia. And we all recognize medically the connection between the two and the influence between the two. And in particularly during COVID, 75% of people that went to the hospital had underlying diabetes or hypertension. And so we know that this is important, but somehow as a system, we're not quite there yet at recognizing the medical savings from mental health, such that the insurance companies are rolling it out in mass scale to support our society, and particularly adolescents. 75% of mental health is diagnosed before age 24. And we have very limited support for adolescents in this country. So I think we are at a turning point where we have to embrace the reality here and get the whole system. I think the employers are leading, which is fantastic. And we need to get the insurance companies and the whole system to move forward. And then as far as demand goes, the great thing about technology-enabled services like Vida is that we can use, we have a provider network in 50 states, and we are a medical service provider, but we can use technology to automate some of the things that a provider would normally do offline. And we can use day-to-day messaging and content and groups and interactivity to make it easier for people to find other groups that, whether they're going through the same thing, like to your story, Bambi, like a grieving group, right? You can put people together that are facing the same thing, and they can really connect and help each other in addition to access to the therapist or the psychiatrist. And we can find ways to scale mental health to serve more people in the country.
That's awesome. And I remembered Russ mentioning a similar kind of and almost an algorithmic approach to matching the right intensity need to the right intensity expert in a way. Russ, is that something that you are continuing to advance in meeting the demand and keeping up the quality in a way?
Yeah, it's really important. We think in the long run, this really is very much a supply-demand imbalance problem. You've got far too many people who need care than there are providers to support them. And so you really have to rethink how is care delivered, across the spectrum. And one of the important ways is ensuring that the care they're getting is appropriate for the need. So one of the big issues in the space today, counterintuitively, is that you have a lot of people that are overutilizing certain types of care. And the therapy for years issue, right, where there are chronic conditions where that's appropriate, but they're actually, it's a very small segment of the population. For the most part, a course of therapy, an 8-session, 10-session, 12-session course of therapy, whether it be for cognitive behavioral therapy or dialectical behavioral therapy, like these evidence-based approaches only take a certain amount of time, and then you can step down into a step-down level of care. What we're trying to do is create that step-up, step-down model and use technology to pinpoint where somebody should be based on their needs. And today, we've gotten to the point where our AI is actually better than our live coaches and live clinicians in predicting where somebody should be, what kind of content they should consume, as a direct example. And I think you're just going to see that improve over time based on more and more data, more and more access to outcomes, and then using those outcomes to feed back into the decision-making upstream on where somebody, should be cared for.
I think that we do the same thing. We use CBT and step up and step down. And I agree with Russ that that many people are overserved and they're not measuring outcomes offline. So they just go to endless therapy without actually looking at the actual change in PHQ or GAD. With the advantage of these online services, you can actually measure progress in 12 to 16 weeks and really help someone with self-efficacy at managing day to day. And so you're really lowering the cost overall for providing mental health services.
And that's great, because we've on the physical health side of it, we do that in the form of physical therapy or in the form of time-bound therapy, so that we can have the end result to be better measured. I'm glad it is happening, especially in the workplace. So thank you so much, Russ and Stephanie. I wanted to kind of switch gears to Dr. James Greenblatt. And sorry, I'm pronouncing your name if that is incorrectly. So Dr. Greenblatt, I would like to understand the mind and body connection that we need to also focus on, because we either focus too much on the physical health or mental health, but in your space, you've seen how they play out together. And I wanted to see your approach, which could be on more integrated approach to the mental health conditions or illnesses that people are dealing with. Specifically how, we have seen eating disorders and ADHD, other kind of spur up in the last 2.5 years. At least in my practice, you're seeing more and more of eating disorders and weight changes. So could you elaborate on that mind-body approach from your perspective?
Sure. No, absolutely. I've been practicing child and adolescent adult psychiatry for 30 years, and one foot always in inpatient psychiatry. So I've seen the sickest of our mental health community. And as Russ described, this is not a new problem. I've been worried for about 10, 15 years, and the past 3 years, it's gone from worry to real panic. And I think that in the eating disorder population, it was the perfect storm where rates increased, severity increased, deaths increased, hospitalizations increased, and we have waiting lists now. We didn't 3 years ago, and most facilities around the country, actually the globe, dramatic increases in waiting lists. So it was a perfect storm for this eating disorder. But what it kind of helped me see in a very powerful light is the concern about what Bambi mentioned, the conventional wisdom, and what our treatment model is. For too long, I've been saying psychiatry and mental health has forgotten that we have a neck, that the body is connected to the brain. And as we begin to look at these eating disorder, malnourished kids, we're seeing such significant metabolic, hormonal, and nutritional problems that affect the brain. And, on the flip side, the outcomes of medication is poor, and that's a secret that we don't talk about enough. The outcomes of therapy are variable. And so our work is kind of the integrative functional model, looking at these underlying root causes. And I think we have to try to integrate that into not only our eating disorder world, where we have profoundly malnourished patients, but also into the depression, anxiety, and major mental health conditions.
Do you see more ADHD in your adults and kids in the last 2.5 years? Is that something that is rising, especially with the Zoom classes and?
Oh, I think as a child psychiatrist, most of my colleagues, we had to close our practice because nobody could take new patients.
Oh, wow.
So the incidence is increasing, the severity is increasing, and the age of onset, we're seeing much more disordered younger kids with, there's no such thing now as a patient coming in with ADHD. They're kind of these coexisting anxiety, depression, oppositional defiant disorder. So the presentations are more complicated, particularly for young clinicians coming out of school, and the treatment model is more complicated. And I think it's the tip of the iceberg as to what we're going to be seeing in the next 10 years without better, both mental health services, but also better models of treatment.
So you mentioned the conventional wisdom, and we will dig deeper with all of our panelists on that. But I wanted to bring in Clarice because we talk about kids, and you have been working in that space for a very long time, Clarice, and would like to understand perspective from your side as you're fighting for the schools to be open, for example, really focusing on the connectedness that the kids need to be experiencing and not losing their life skills while dealing with the pandemic. Could you share your perspective, what you're seeing in your space impacting kids, and that one size fits all has affected them, or policies to some extent?
Right. So Clarice Schillinger, I started Back to School USA, a truly grassroots group of parents, children, caregivers, all the above, that have reached out with deep concern about their children. It did start in the pandemic when schools would not open, and has grown into our children are so severely behind now that they're back in the classroom. I actually was just out in California about a month ago and got to see my good friend Bambi. And Bambi, I'm so sorry for your loss. I will remind you of that joyous week that you spent with your family celebrating your brother moving. So that was a really happy time. And I got to at least see some of that. So thank you for sharing your story. It is so incredibly hard for parents to really navigate the new curriculum that has been applied to schools that is really a one size fits all for children. So I try to take a more proactive approach to the mental health, and I'm really fighting for better curriculum for our students and our children to give them purpose and tools in life. I believe that if children have purpose, it is more likely that they will not go down the road of crime, and hopefully that the mental health will follow suit and be richer than poorer than we have seen right now. So what I mean by that is, our nation's report card in America came out 2 days ago and has shown a steep decline in our children. So if they are leaving school without the ability to read, write, and arithmetic properly, I think that it does follow suit that mental health will also go along with this. So if you're not able to go to the grocery store and afford that grocery bill because you're not making as much, because you're not educated correctly, that all ties in with one another. And I think that we really have to get back to the basics instead of, I see a lot of policy being pushed for curriculum that is inclusive, that's diverse. And I do agree, but I do not agree with taking out honor level classes, removing, children from social activities and community centers, and all these things that were closed for 2 years really put a stain on our children, not to be ignored while they've been sitting in front of screens for 2 years at home during school closures. They also were severely isolated from their teachers, their friends, their peers. So there's been many studies. There's studies in the UK, there's studies in America that show the connection between social media, virtual learning, binge watching TV. That's what our teens, our adolescents are doing right now, this constant stream of media. So if they go into the classroom and they're being taught something, and then they go into their social media and they go on to, binge watching a show, and every single source is saying, I need to stop eating because I'm supposed to look like this. That is constant reinforcement. And we really have an issue with the media along with our education system and the current curriculum.
Yeah, and one of the things that we have also seen in the statistics is that the kids with special needs, or the kids with less resources, were most impacted because their main source of not just learning but even care was from school. Maybe even the meal programs were also from school. So it has been rather kind of a health equity issue as we were closing down the schools, that it was disproportionately impacting kids who needed more of our attention.
So I'm sorry to just real quick, I would love to give you an example of just that. Is I am in Philadelphia, 16% of children, the schools were closed for 2 years, 16% of children did not have a device. That means that they were not provided with a laptop to do virtual learning. 2 years without the device they needed to do school, that's 16%. And when we hear from the doctors and these mental health professionals, think about what 16% looks like in your field. What does that look like in the emergency room? I have pictures of children laying in the emergency room for a week waiting on a mental health bed.
Yeah. So Bambi, yeah.
Yeah, let me jump in. And I think thank you for, running with the ball here, most of this, thank you, most of this session. But I do want to jump in here and talk again a little bit about conventional wisdom. Let me want to shift this back over to Ram, because, you and I had a discussion, Ram, about the way we've been handling sort of these medical decisions, the way we've been handling these policies, as Clarice mentioned with the lockdowns, the way we've been handling this in the last 2 years. And also to your point, Dr. Greenblatt, the way we've been, diagnosing mental health symptoms, it's all been this sort of conventional wisdom of how to go about it, established by the medical establishment. And Ram, you and I had a discussion about how it's somewhat disconcerting to feel that the last 2 years, the way we've been approaching our healthcare approach has been very top down, very one size fits all. And there's been very little discussion about whether we are doing the right thing. And I think that has implications on how we conduct science. I think that has implications on how we conduct or approach healthcare and the healthcare protocols we have. That has implications on what we call evidence-based treatments. And I'd love for you to touch on that as from your view as a scientist and doctor.
Yeah, there's so much I could say about this. I mean, my PhD background is sort of a mix of machine learning, I call it statistical computing, but basically predictive algorithms, optimization. It's very data driven. It's very focused around handling uncertainty and still being able to arrive at a high quality decision. We have lots of ways that, and I'm going to take it at a very broad level and then try to bring it down specifically. We have a way of talking about experts in terms of degrees and credentials, and that's not how I think about an expert. Those things can confer particular training, but you can walk through a degree program and have learned little to nothing in terms of applicable skills when you're challenged with something that's novel and different. The way I look at expertise is an expert is someone who, when faced with uncertainty, is more right than wrong. What do I mean by that? If we're faced with certainty, more often than not, we don't really need someone's opinion. I mean, granted, sometimes what we're describing as certain is not certain, but there are clear circumstances where that's the case. And even then, if there's deviations, they're pretty minor. When we're talking about uncertainty, which we faced probably at a level that most of us haven't really experienced, say in February and March of 2020, the way to approach that is an open mind and to gather opinions and to gather different thoughts. The way not to approach that is to suppress and to take I only have one word for it, and unfortunately it's loaded, an authoritarian approach to deciding what is truth, what is correct, and more importantly, not updating your priors. If you've decided that there's a particular approach or policy that is clearly correct, and you're dealing with a lot of uncertainty, at the very least, you need to be humble, or coming back to the topic of humility, interestingly enough, to come back and reassess your priors. Were your priors correct? We knew very early on, certainly by May of 2020, that transmission in schools was very low. There are lots of physiologic reasons for this, and I'm happy to get into that. And we know that studies since then have confirmed that. The current national conversation is we didn't know, and that's wrong. That is wrong. And if we continue to try and engage in this sort of what I call outright gaslighting, and I've been quoted as such in international articles, I don't hold back on this, we're not going to learn what we need to learn. We knew early on, and so we had ways of mitigating the harm. And so, at a very broad level, when we talk about the central question around not providing personalized recommendations, we could even just look at age cohorts and risk cohorts, in terms of COVID and its impact and how we might approach risk mitigation in those scenarios. And I can go on and on about this. I've written 40 and 70-page declarations with 90 to 120 references for various courts and what have you, and I could go on and on, but it goes well beyond the larger point. You tell me how deep to go, but I think fundamentally when it comes to risk stratification and high quality decision analytic approaches to tailoring your decision to the circumstances that are relevant to the individual in particular, or the cohort in particular, we completely failed. Completely failed. And the question comes back to why. And I could also go on and on about that, but let me stop speaking for a moment and let other people chime in.
Yeah, and maybe in that same order, if you could ask, thank you, Dr. Ram. Russ, what did you see in your arena, how conventional wisdom kind of played out? Or didn't work out?
Yeah, I mean, I would say, first of all, as a organization that's been focused on trying to change status quo and rethink how the mental health care system works, we've never really been attached to conventional wisdom, right? So I think that we saw from the very early days of, I mean, we were founded in 2011. And, you know, so over a decade ago, the recognition was there that measurement wasn't really a thing in mental health, certainly not at any sort of scale. And so there was no way to, in a focused way, use data to improve. If you're not measuring it, there's no such thing as improvement, right? And there are even some studies from back then that show any measurement at all doesn't require any action on that measurement. Any measurement at all leads to 25% better outcomes in mental health. So all you have to do is actually measure. Ignore it, you're still going to get better outcomes. And so, you know, early days, we basically looked at that and said, okay, let's start by measuring. Let's start by actually collecting data using mobile devices. Let's figure out if that data is predictive in any way. And let's, you know, the first goal here was actually to provide providers with data, you know, make it easy to collect and just provide them with data, and then let them make decisions based on that. Very quickly, we realized, okay, measurement is important, but it's not the most important thing. The most important thing is access. And that's where we've really spent the vast majority of our time. And when you look at what's happened over the last period, it's an interesting dichotomy. Again, let's get away from conventional wisdom. The pandemic's actually been positive from an access standpoint, right? The pandemic has forced those who said, yo, you can't do therapy using telehealth, right? You need to see someone in person, right?
Yeah.
Turns out that's not only not true, but the outcomes are as good, if not better. And a lot of that just comes down to people being willing to show up to, you know, the stigma is far reduced. You have a situation in this country with 50% of counties that have zero mental health providers within county lines. Some of those counties are 100 miles wide, by the way, right? So zero mental health providers. For those counties where there is a mental health provider, everybody knows everybody. So you drive up and you park in their parking lot, and they're like, oh, you know, Benny is at the county, you know, psychiatrist office. There is no privacy there. And so it makes it very difficult for people to, you know, drive. But right now I could be sitting in the comfort of my home. You know, I can be you know, seeing somebody that is far more comfortable. So the pandemic, I believe, has shifted forever the understanding that telehealth works, that you can be very successful treating things virtually, and that's been a wonderful shift in perception and understanding. And again, like, I'll caveat it all with, there are certainly some conditions that need inpatient in person.
Yeah.
But the vast majority of mental health care can happen via telehealth, and that's been a huge positive.
Yeah, so it seems like from Ram's perspective, conventional wisdom didn't work out from the COVID response perspective, but it seems like from mental health access perspective, not doing conventional medicine, conventional wisdom did work out to help the patient, to help solutions and scaling it. And Stephanie, from your perspective, what are you seeing? How addressing or following through with the conventional wisdom or going against it almost kind of, and that has helped or not helped?
Well, I think in addition to the conversations we've had about conventional wisdom, there has been a recognition out of COVID, not just that mental health is pervasively needed, but also that the people who were admitted to hospitals and who died from COVID had underlying diabetes and hypertension and depression and anxiety. So there's a recognition of the mind and the body connected. And we've known this for a long time. When we first started with cardiometabolic with diabetes, and we had our coaches say to us, and dietitians and registered diabetes educators say to us, I can't treat the diabetes without treating the depression, and vice versa. And so if you look at individuals that are, between $10,000 and $20,000 annually in the system, and they have co-occurring chronic disease like a diabetes or a hypertension or hyperlipidemia with depression, anxiety, they tend to be 4 to 6 times more expensive. And so we have to treat both together. And I think that's coming to the forefront as well from the pandemic, because we were stuck at home and physical and mental health all came together. And actually what worked during the pandemic, to Russ's point, like people were comfortable going online and doing therapy. They were less comfortable going into they did telehealth for a while. So what you see, when you look at the statistics, telehealth peaked at 64% of visits in May of, I think, 2021. And then it went back down. And once things opened up, people wanted to go see their doctor in person, and it went down to 20%. But mental health stayed above 40%. People prefer mental health, through telemedicine, through video, synchronous video, through asynchronous chat. And you're seeing people really benefit from being in these modalities, these different modalities where it is a tech-enabled service. You're getting access to a provider, but you're using chat or instant connection or asynchronous chat, or you're using groups or things like that. And so I think there's a lot of proof that, and I don't think we're going back ever, that this is the way mental health should be treated going forward. There's also evidence that you need to think about them together, the mind and the body, and you can't isolate them. And I think there's also recognition that, mental health does drive a lot of the costs up. There's been a lot of sort of fear, uncertainty, and doubt around how much impact mental health truly has on our whole healthcare system. And I think COVID changed that.
Mm-hmm. That's really so we learned from not sticking to the conventional wisdom and really driving new data to kind of support the new way of healthcare delivery in a way. And Dr. James, what are you seeing? Staying with conventional wisdom has helped us, or not so much?
Well, it's really frustrating because I have a different perspective being, after RAM sees a patient, I end up in the hospital. And as much as we're improving access and telehealth is incredibly supportive and technology is making huge inroads, we can just go through the list, overdoses, addictions increasing, overdoses increasing, suicide rates increasing. So with all this improvement in the kind of model and the access, there's still something wrong with the system. And that's why we need to kind of, rethink and add to the model. It's not just about access.
Mm-hmm. Is that more policy focused, or is that more politics focused, or yes?
I think it's all the above. Policy, politics, absolutely. There's billions of dollars being thrown around, but where and how? But again, most of my work over the years has been just kind of redefining the model and looking at more of a mind-body or biological approach to major mental illness. It is not just stress, There's major metabolic, genetic, nutritional, hormonal challenges. I think COVID, with all its craziness in terms of policy and healthcare, it certainly made us rely on testing, right? We have all these tests at home. Is it a cold or is it COVID? You go to a psychiatrist or mental health professional, there's no such thing as an objective test. There's no blood test, there's no x-ray. There's no way we examine what we're treating. And as Russ said, doing anything in depression, you're going to get 20, 30% of people getting better. And whether we call that placebo or therapeutic alliance, but there are 60% of patients that aren't getting better. And we're calling those treatment refractory. And those are the ones drifting to homelessness in prisons and the suicide and addiction. So there's just a huge chunk of this conventional wisdom that I think is being ignored.
Yeah, Archana, let me jump in here that I think I do agree with Russ that we need to have access, but access to what, right? If it's access to conventional wisdom and these old ways of treating or old ways of viewing the mind and body separately, then what are we really doing? And so Dr. Greenblatt, maybe to make it illustrate for everyone, what's really happening sometimes that you see when you see patients who are diagnosed with, say, ADHD or some sort of mental health symptom, but they really have a bad diet. And it's not a PHQ-9 that they should be filling out, but maybe they should be taking a simple lab test, blood test, to find out if they're deficient in vitamin D or some other, nutrients.
Yeah, I mean, the list is endless. I think we're pretty clear that lifestyle and diet is going to help us live longer and feel better when we older. I think it's a struggle for parents with kids, particularly, kids in poverty, eating healthy foods. And we've been through, Flint and Mississippi and lead and copper profoundly affecting the mental health of these kids. So some very simple nutritional testing can make a difference. And a very simple changing in our practices can support children onto a healthier path. And it's really just ignored often until it's too late.
Yeah. And I want to bring it to Clarice because, the conventional wisdom is something that you have been challenging and bringing to forefront, almost kind of in the light how Dr. Ram is doing from inside the system in a way, using his scientific skills. Clarice, you're using your advocacy skills to kind of help, almost kind of refining the conventional wisdom or challenging that. Can you share, is it working for us, or what aspect of that has worked and what aspect of that did not work for the kids specifically?
So the reality is that the majority of students do better with in-person instruction or some type of human interaction. It was said earlier on this webinar was, we are all human and we need that interaction with people. So, during the 2 years of this lockdown, I think that it became very obvious that our children need human interaction to really, thrive in life. Whether I'm not discounting homeschooling. What I'm saying is, when everything was shut down, that's when it really became the issue. The, churches and community centers and extracurriculars is where we really saw the rise in the mental health. I will bring it back to policy and politics because that is where I see a lot of the issue. We've had billions of dollars put into a fund for mental health, for our schools, for our everywhere. This money was allocated, billions of dollars, and there's only been 85% of that money, even the 15% is only spent. 85% is still sitting in the coffers waiting for someone to tell the government where to put this and where to spend it, while we have these brilliant people saying we have a true crisis here, and our children and our adolescents and young adults need help. And we're just sitting on billions of dollars on where and what to do with it. So I do challenge, I challenge that our government becomes more urgent in these matters, instead of just sitting on the sidelines, watching our children turn, sick to crime to all the above.
Yeah.
I
Well,
think I wanted to just piggyback on that, because I think conventional wisdom prior to COVID was, oh, well, the teachers will and the government will help you teach your children, right? And then all of a sudden COVID hit and we were all homeschooling our children. I certainly had to do that. And so now that's even changing in terms of the participation of parents' involvement in the education of their children. And we're seeing a bit of a fight for that, though. But you talk to a lot of moms and a lot of school boards. What is where is that shifting in terms of how much parents want to be involved?
So, it's really shifting, and why that shift came about was, a lot of people, if you watch the news, you'll see the radical agendas that people are fighting. But I don't think that people should overlook that the reason parents got so involved is they would hear their children's all day on the Zoom class, and sometimes they would sit there all day and watch a movie. So that's the reality of what was happening. Yes, we have radical agendas trying to be pushed in our classrooms, but also just the lack of engagement. So, across the nation, parents are demanding transparency and involvement in their child's education because of what they're seeing at home. They're seeing mental health. They're seeing a rise in gender dysphoria, a rise in anxiety, a rise in depression, all these things are just compiling, and they look to the school and say, you have my children more waking hours than I do. So there's something wrong here, and I need to be more involved in ensuring that they are educated and they have the purpose and the tools that they need to be successful. I think a lot of times our media is getting this very conflicted. Parents just want to make sure their child, whatever level or whatever skill set they have, is being really capitalized on, and making sure that the child feels confident and has purpose in who they are.
Yeah, and I do feel that, our children's support system is of course beyond parents, but also teachers too. And what we noticed is that the teachers were, of course, overnight asked to go virtual, but they were also slower to catch on to policies. For example, that when the mask mandate was relaxed, that didn't arrive to classrooms fast enough, and that allows for students, especially with language issues or hearing disablement, they cannot wear the mask because it affects their learning. That did not follow through, even though CDC did pull through. So there's a lot that is upon the entire ecosystem to kind of move along around our kids to kind of progress that mental health agenda, because all of the touch points that we have with our students are being impacted. The teachers are taking time off or having strikes around this, and not thinking, how is that impacting the kids too? And I have ample sympathy for the teachers too, because I'm also, as a clinician, seeing patients and being on the front end. And of course, exposure isn't a concern and other things, but the students' well-being becomes really important besides the academic. And that got impacted when we did not follow through on policies that existed in real time.
So Russell, I thought, made such a great point when he said about the masking and altering some of your breathing and creating these weird breathing patterns. I've seen it. I've experienced it myself. In fact, and you know, having a kindergartner sit for 8 hours with that is really, you know, it can really mess with your breathing, and you know, you have all of the toxins, was what I believe, back and forth throughout the day. I think that it's very important to note that we do have a very powerful infrastructure that is politically driven over our public school system nationwide. That's unionization of the public schools that have really sat at the decision-making table with the CDC, with the president, and really implemented and pressed for these policies to be pushed across America. And it has trickled down to affect every single person. Many moms say to me, I just don't want the government at my kitchen table. I just want to make sure my children are educated properly, academic excellence, so that they don't fall into a statistic of mental health and all the above that is rising right now.
So with somewhat of a doom and gloom kind of situation here, especially for the younger kids, but I wanted to quickly go around the table as we come to the close of this panel to see what can we look forward to, what can we do differently that can help enhance the current mental health crises, and what are you in your universe doing differently in the next 1 year to 5 years that could be innovative or uniquely different that helps us in the mental health crises. So I will go backwards at this time. So Clarice, I'll put you on the spot, and then James, and then thereafter. Go ahead.
So just like anybody has in business has competition, and I do and will advocate for competition within our education system to ensure that children have the ability to go to school where they prefer or take classes how they prefer, not just based on their zip code. I think that is a major contributor to mental health and will help trickle down, that if children feel like they are being empowered in their classroom of their choice, it will help the rise in mental health.
Excellent. So having more choice, a more customized, personalized.
So it's not necessarily, not every single child has to go to the public school. There's charter schools, there's private schools, there's virtual schools, if that's what's best for the child. There's trade schools. And I believe that it is the right of the parents and taxpayers that they can take their money and put it in the institution that meets their child's needs.
Great. Dr. James, what would you suggest we could do differently in the next 1 to 5 years that could help your patients?
Yeah, I think as we've, cracked the walls of kind of shame and stigma of mental health, and we're increasing access and technology is helping, I just urge everyone to not forget that there are some deep, deep holes in the model, and both a kind of research, a biologically based understanding of mental health and mental illness and genetics will make a difference. And for me, the next 5 years is really just focused on educating mental health clinicians, psychiatrists, and behavioral health clinicians on this term, this world of integrative and functional medicine that I think can extend the model and improve outcomes.
And Dr. Ram?
Yes, I just wanted to close by just bringing up a very important point that James brought up, is that it's not uncommon for individuals who require inpatient care to sit in an emergency department for days, especially for pediatric adolescent beds. And imagine a 7-year-old sitting in the chaos in an emergency department that grates my nerves out of 12 hours of a shift, day in, day out, for days, waiting for a bed. under the auspices of trying to protect their mental health. Just that sentence sounds absurd, because it is. So in terms of breaking the model, I mean, there's a lot of things that I'm doing, bringing my particular perspective and my skills to organizations like California Parent Power that Clarice may be familiar with, and helping them advocate for better policies around the state. I've testified in Sacramento. I've been very apolitical for most of my life, and that's fine, that's good. And I'm not saying I'm political now, but I'm at a stage in my life where I've accumulated quite a bit of experience, both clinically and quantitatively, and just life experience as a parent, where I'm utilizing that to now give back, and as much as I can, without asking for anything in return, except for something better for the kids and better for my family in the future. And, to my original point when I was talking about what James said, the inpatient model for kids is, and maybe for young adults in general, is interesting. It serves some very clear medical needs, but perhaps we need to look at different ways of maybe structured living environments for kids and get them out of the ER as quickly as possible, using innovative solutions where they can get to folks like James and people that James trains, that are as simple as a home. They didn't need to be a hospital. They don't need monitors. They need care. They need attention, and whatever that means. And some of the kids who are very metabolically unhealthy with severe eating disorders and major metabolic perturbations from that, yeah, absolutely. They need both inpatient medical and psychiatric care. But that's not the majority of the kids that are waiting for beds. So we need to fix this. And there is a big role for innovation. And I've talked to some people about it in terms of creating outpatient, quasi-inpatient models that are just not hospital-based. But there's a lot that we can all do. And part of that just means giving.
Yeah. Thank you. So we do need to innovate the inpatient situation for kids and young adults in a way, so that we can have health at home. So coming to Stephanie, what can you say we can do differently in the next 1 to 5 years that could fundamentally alter the current crisis?
Well, I think first and foremost, as a CEO and leader, and then as a mom, I have 2 boys, is really bringing the behavioral health and mental health pieces to the forefront in schools and in the workplace, and reducing stigma, making it part of the vernacular, and a clear mandate that we should lead with empathy and compassion, and that everyone needs, really mental health essentially to be productive and happy. And this has been shunned in the past in the workforce and in schools, and it's got to be front and center. We work with the largest teachers union in California, and during the COVID, the teachers really embraced, figuring out how to be better with, and they knew they needed mental health, right? So we just have to keep this conversation going and put it front and center. And I do think for higher acuity substance use, and particularly in Medicare and Medicaid, where there's social determinants, we have to solve the social determinants. We have to look at quality of food, quality of housing, and certainly teens who are in hospitals that shouldn't be, and they should be in different types of service centers. We need to innovate on the types of care in person for the higher acuity. And we need to embrace the Mental Health Parity Act. We've talked about the Mental Health Parity Act for so long, but we haven't executed against it.
So that's what you want to see in the next 1 to 5 years. Russ, thank you for answering that question around the 2,000 to 3,000 health savings that Cigna has studied upon. So we do have the link that we could share. So Russ, what would you want to see change and alter in the next 1 to 5 years through innovation and others to improve the healthcare crises?
Yeah, a few quick things, and I think it's it's multi-tenant, right? There's a lot of things that need to be solved. One, to piggyback on what Stephanie said, we have to get children educated about how to take care of their mental health and build resilience earlier, right? So we've got physical education, we need to have mental health education. We are building a program where educators now can get access to Headspace, they can get access to a curriculum so that they can start teaching children how to build a mindfulness and meditation practice, which we know builds immense resilience to the ups and downs of the world. Like the world is not going to get any easier. So we have to build resilience to it. 2 then is models for mental health care that are focused on bending the cost curve. Right now, the incentives are not, we talked about too much therapy, but the incentives are actually for therapists just to keep patients coming, because new patients are harder to manage and they often don't show up, right? So we've got to figure out models that bend that cost curve, that create incentives to get the right patients to the right care and get them out as soon as they're able to. And then finally, we've got to change the regulatory environment. I would say that the percentage of dollars we spend as a 50-state medical provider on managing state-to-state regulations is insanity, right? All of that money, which could be going to high-quality care, instead is going to legal costs, regulatory costs, making sure we're on top of the different filings we need to do. We have to get rid of that system. High quality care should be high quality care across state lines. And I would say that's the last thing that could really help here in the next 1 to 5 years.
Thank you. Thank you. And I really love the fact that you're providing that module for the teachers so that they can teach the students to learn to use the different muscle in the brain early on. So Bambi, I'm going to turn it to you. What would you like to see in the next 1 to 5 years that could alter the mental health crises for us?
Did we already ask Dr. Greenblatt that question as well?
Yes.
Okay.
We've asked all of our panelists that question.
Okay. I think all of those are really relevant. I'm going to go back to sort of the things that I talked about earlier, and maybe what Ram also touched on, which is the humility. Ultimately, we can talk about regulations, we can talk about policy, we can talk about technology, and we can talk about how to treat people and treat ourselves and how to treat our kids. But ultimately, it comes down to how we train ourselves and how we educate our children. I would like to see a place where we don't constantly have a hyper focus on safe places. I really find that to be extremely detrimental to the children. I think that one of the best ways we can help ourselves in our mental health is to face our fears and, get through the dark days and not just brush it off as though not to brush it off and be afraid of it, because all of those dark moments create a better person in us. And so we as a society need to teach our children that it's good to feel insecure. It's good to feel inadequate. It's good to feel that you don't have it all together. And because guess what? Nobody else does. And so you don't have to find other people to affirm who you are. I think that's what we need to do as a society. I would love to see more of that.
Thank you. And I would love, I'll answer this as a clinician, and then I'll answer that as a parent. So I would love to see what Dr. Ram and Dr. James said, that we do need a changed approach of mental health in the clinical setting, because that is the first place possibly that we see the patient with mental health issues, and possibly the last place that they see us before something bad happens to them. That's kind of like the problem that as clinicians, we're not paying enough time and attention to how we solve for this. And I think we need, of course, better training of our clinicians, but also integrating mental health deeply into primary care. because primary care is the first phase that the patient or the person really sees. So I would love to see more training of primary care, more incentivizing and reimbursing their time so that they can address mental health issues, screen and intervene early on. As a parent, I would say that we are all living in nuclear families. We are not living in a social support system. Our kids need to be able to learn to volunteer in the communities. I think that's one thing that is absolutely missing in the school system. We teach math, we teach English, but we do not teach how to coexist with others and help out, because you cannot be helping and resentful at the same time. You can't have empathy and resentment at the same time in your head. So we need to shift the brain of kids from negative to positive. And I love what somebody mentioned, is that aside from PHQ-9 and GAD-7, we do need to look at, functional scales, happiness index and others, starting right from childhood, but also in adulthood, in workplaces, because those things come way earlier than we start seeing the PHQ-9s and GAD-7, which is the anxiety and depression scales to decline. We start to see happiness, trust levels decline of individuals, and hopelessness increases. So I'm hoping to see that more kind of systemic approach to addressing them. Bambi.
I think Archana, you know how to do this. We can move on. Thank our panelists for an amazing discussion. And thank you, Archana, for taking much of the lead there.
Thank you, everyone, for joining in for this this important mental health crisis topic, and hope we walk away with doing something good so we can fundamentally change this. So appreciate all of you to joining in, and I look forward to having you stick around and see the next panel.